All right, well, welcome to our fourth podcast, everyone. This is another of the series hosted by the North American Spine Society. I'm Dr. Mark Erwin. I'm a assistant professor at the University of Toronto in the Department of Surgery and Divisions of Orthopedic and Neurological Surgery. I'm joined by my colleague, Dr. Zorica Buser. Zori, you going to introduce yourself?
Yeah, absolutely. Good afternoon, everyone. As Mark said, thank you for joining us. My name is Zorica Buser. I'm an assistant professor of research at the Department of Orthopedic Surgery at NYU, and also director of research and regenerative medicine at Gerling Institute.
Thanks, Zori. We're delighted to be joined in our talk today. The title of today's podcast really is repair of the intervertebral disc annulus fibrosis. Is it a possibility or a pipe dream? So we're delighted to be joined today by Dr. Ashish Diwan, who is the director of the Spinal Lab and Spine Service and postgraduate coordinator at the School of Clinical Medicine at University of North South Wales Medicine and Health at St. George and Sutherland Clinical Campus in Surgery at St. George Hospital in Australia. So Ashish, welcome, and thank you very much for taking the time to join us today. We look forward to your expertise and experience to help us along this difficult topic. So I guess the thing is that, the degeneration of the disc begins, no one knows exactly where, whether it's the nucleus, the annulus, end plates, all three contributing somehow. It's a little unclear, but it's clear as day that with progressive degeneration, there is damage to the annulus. Fiber interruption, the disc may bulge, the disc may actually tear, the so-called prolapse disc or herniated disc. The question there is, discectomies can be performed in appropriate cases, and often that's it. And the surgeon has to take a 15 blade or something to make a little larger size entrance to the disc in order to remove any protruded segments and any loose fragments to come out of the nucleus. Then what do you do with the tear in the annulus? I think again, Ashish, will look forward to you for this, but historically, it's been left to kind of scar over by itself. And about 5 to 7%, according to literature, of cases will undergo recurrent herniation, likely associated with at least impaired healing there. So the question really is there anything we can do about this? Is there any way we can mitigate against this potential for herniation or progressive degeneration associated with annular damage? So Ashish, if I can ask you the first question maybe with this, you could tell us as a surgeon, you could lay out some of the challenges involved in attempted repairs of the annulus. That's the tissue quality, heterogeneity, and the cellular morphology and the fibro alignment, and all that is very complicated in the inner and outer annulus. How would you, as a surgeon, approach trying to resolve this?
Mark, at the outset, first allow me to thank you and Zori for inviting me to this podcast. Pleasure. And I'd also like to thank NAS for, giving us all this opportunity to delve into this extremely complex and something extremely common issue, which continues to bother, all of us, scientists, surgeons, patients, payers, just about everybody. Somebody at a meeting said that discectomy is not a benign operation. The consequences can be humongous. And most of those issues relate to this structure that we want to devote our time today to, which is the annulus. So this is a good segue to actually review that structure itself. We talk about the annulus as the outer layer within the disc. The disc we consider to be an organ structure where you have the end plate, the nucleus. Coming again to the annulus, you talked about the fibers, how they crisscross, go from bottom to top. One of the things to consider here is that these fibers, when you see in the diagram, you see a very nice little sketch, which there's a cartoon, you see an end plate and somebody's just put a line across saying this is the annulus. The reality is that is not the case. These fibers, like what we describe as Sharpie's fibers, where tendons insert into bone and all, actually penetrate into these bony structures. So that is something that happens on the top and bottom. Then on the inner side, you have this nucleus, which is not separate. When we show on an MRI scans, we say this is white, this is nucleus. It is not like separate floating structure. There's a transition zone And these structures, the proteoglycans, may be very tenaciously attached to the inside of the nucleus. On the outer side, you have areolar tissues, you have small sympathetic nerves, you have other innervation structures, which when there is an injury, they respond by sort of innervating the outer annulus, which we have hypothesized could be also a source of pain. And then let us come back into the inside. Layer after layer of annulus is not just collagen, but intermingled within that is a very complex interplay of cells and small connective tissues. Recently, we have talked about elastin being present in those interlamellar spaces, if you may call that. And each one of them has a role, either in keeping it bound together or contributing to its tensile or elastic strength, depending on, it gives you a torsion ability. I think there may be some new understanding also around some of the compressive loads that also the annulus takes. Then you mentioned about the two issues, about the process of degeneration, and then we spoke about how surgeons access it and look at it during discectomy. So if you look at what happens naturally, the degenerative process where the lamellae separate, or there's desiccation, or there's cellular atrophy, where the annulus is not fully tear, layer after layer are not torn and the nucleus has not gone off, for the want of anything better, a similarity that I talk about when I'm teaching undergrads is that this is equivalent of angina in the heart, so as to say, the degenerative disc disease then leading to pain. So that is the equivalent of that. And when you have a frank lumbar disc herniation, or in the past we used to call it herniated nucleus pulposus, that is like a heart attack. It's a catastrophic failure of the disc. And that is something we need to understand, that what we are trying to do is try to repair a catastrophic failure of an organ. So when you start looking at, let us say, if your liver has failed, your kidney has failed, how do you handle that? You have much better tools. Our tools are restricted for the reasons you said. So when you have this situation of a lumbar disc herniation, what we are addressing clinically is the compression on the nerve root alone. That is all that we are worried about, because that gives us good clinical outcome. And frankly, we can stop there. Traditionally, we have said it's a good operation, gives good clinical outcome. The question then we ask is, why bother doing anything else? An operation that has worked for 100 years, why do we change it? The reason we need to change it is nearly 20%, that is 1/5 of these patients over the next 6 to 7 years will undergo another operation. So what that means is, in this pool of people who have had the microdiscectomy, we're looking at least 50% of them are unsatisfied. So does it become important, to address that annulus, which may be a source of reherniation, which is one of the causes for reoperation, the other being continuous collapse of the disc height, which causes back pain, which is the other one. But let's address just at least one part. If we can decrease that 20% to 12% or 10%, I think we'll be happy. We would have contributed something in our lifetime before the next generation of spinal surgeon and scientists take over. So we look at it and we agonize. And that is the modern sort of folk every spine surgeon faces in their life. You go in, you have exposed, gone into the canal, you use a scope, you use a microscope, you use loops, whatever you do. You get in there, you've taken out the disc and you pause. Should I take out more disc? Should I stop now? That is one pause. And the second pause is you look at the annulus and say, oh my God, this one has just got a little puncture hole. This will be all right. No, this is a broad-based sort of a herniation. It is not a sessile or pedunculated, a pedunculated and sessile herniation. We differentiate between them. And all of that is related to how incompetent is that annulus. And at that stage, we sort of say, oops, this is going to reherniate. There's a broad-based herniation. All the tissues look crappy. There's layers and layers which go in there. And again, another situation which we see mostly in youngsters is that when that annulus fails, it is not just an annular tear, it actually rips off a piece of the bone. the osteochondral fragment. And that is another source of worry. Can we push it back? Can we take it out, put something else? So where are we in 2023 with this? Over the past 20, 25 years, we've made so many attempts trying to put stitches across. I see some surgeons very elegantly, they can put nice stitches across, but at the same time, they say, this gets ripped off. Then you have an annulus repair device, a more sophisticated way of just throwing the same stitches, mostly made of polyglycolic acid. And then we had a barricade device where we tried to put a structure on, anchor it on the plate below, and there's a polyester hinge which tried to stop. It's like putting a gate, into a barn's door after the cattle have, escaped, essentially, to put it so. And each one of them has worked at times, but has never become an acceptable practice because the outcomes have not been dramatically different than just getting a discectomy alone. So you get in there, all those things you said, crappy tissue, it is like putting that stitch into wet toilet paper, if I may be allowed that simile. Trying to put a barricade in is an increase in the operation time. You're retracting the nerves a little bit more. Revising a metal which is already anchored in can become another set of challenge. So all of those are posing peculiar challenges. And to answer, if I can avoid this long-winded question, the answer to your question is we are struggling to find a solution. We don't have one right now. And it is a difficult problem to solve for all those reasons, in terms of anatomical location, in terms of quality of the structure that we are repairing, and our attempts in trying to reverse a catastrophic failure of an organ, which we know is a critical structure in the spinal column.
So Ashish, an excellent point. So when you think about a possibility to at all have a regenerative biologic or methodology to repair annulus as a main source, you really nicely outlined the different types of matrix we have in the annulus, that it's populated by cells as well. And then, as you said, given the disc is this really tough organ where we don't have much vascularization, innervation, even the nutrient supply comes from the side of the annulus and through end plate. So do you think that we should be focusing on repairing the matrix itself when it comes to annulus, or maybe somehow find a combination with matrix and cells? Because when we think about nucleus, and that's going to be our next podcast, people very often focus, okay, we have to inject cells. So where do you think we should head with annulus? And I know a lot of that is still in vitro translational research when it comes to annular repair.
Yeah, Vince, let me address the three strategies first, and then talk about the bigger sort of engineering approach or strategy which we may have to deploy. So the question when it comes to repairing an organ or creating a tissue engineering strategy boils down to either using a cell, a scaffold, or a signal, or a combination of all of those, right? And each one of them is under investigation, may have a role. We do not know definitely which one of them will work. But if we start looking at, the previous experiences, what happened with bone tissue engineering or other tissue, other cell engineering stuff, we always know that there is a big role of signaling molecule. And that, is way ahead when it comes to applicability in clinical settings to deliver good results, predictable results. It becomes easy to deliver them at point of delivery. It's very difficult to create a cell manufacturing unit which is GMP compliant for a non-lethal, non-paralytic condition of trying to repair the annulus. The cost will be humongous. Even if we bring the cost down, It will not be scalable because we won't be able to apply it to all nations, all countries. Every country will have a different regulatory pathway for cell strategy, and there'll be countries which, if truly cannot be able to afford those things. So with all of those things, my focus, and I would say where the focus should be, is in either getting a signaling molecule or using a scaffold, or a combination of the two, where the scaffold also acts as a delivery vehicle for the signaling molecule. So that is the sort of long and short approach to it. The question then is, at what stage do we use it, and what the consequence of that signaling molecule is in an operative setting when we have done the discectomy, we have put the nerve aside, and you put a signaling molecule, then what happens to the nerve roots? How do they respond to that? How do we contain that signal in that area? So that then is a good segue to start developing, okay, these are our 7 or 8 criteria that we need to meet to develop an annular repair solution, which is biologic. There is an active ingredient in it. And when you apply it there, it then stimulates the local autologous cellular structures or other structural elements to reassemble in a manner that healing is satisfactory, and that healing not just occurs in a visual way, but also withstands the biomechanical pressures that are put across there. So that is where I think if we establish those criteria and then sit down and look at the portfolio that we have right now, each one of us is working with one or the other, put our minds together, I think we may be able to come up with a clinically, relevant piece, hopefully by the end of this decade.
Yeah, no, definitely. And I love you mentioned the biomechanical side and the load. Very often, obviously, and it has to start in the lab, in a petri dish, and go into an animal model before we get into a clinical setting. But what we've seen in the past is that unfortunately a lot of disc biologics, if we just call all these different combinations, fail because they work great in this translational setting, but then when you bring it into a clinical setting in patients, they fail because of the load. Load is different, animal models are different. So as we put our minds together and start thinking how to devise this annular fibrosis strategy, how do you think people should tie the loading of the disc that in quadrupedal animals or a tail model, rat tail model, obviously works very differently, and how to bring it more that has clinical meaningful implication?
Such a valid question. When I sent Mark my list of affiliations now, on the bottom is I chair a collaborative research committee across the area health district. So it's 1 million people that we serve. And one of the things, after having spent a lifetime operating on people, doing mechanobiology research, doing biomechanical research, this phase of my life, that role is effectively trying to do is to say, actually, how does research translate into real practice? Now, let me tell you, that is the most difficult and impossible task that I have really come across, because, there is real research and then there are real problems with real people. Bridging that is a very, very, very difficult job. So to answer your question in this setting, I think one of the things we have to realize, and Mark and I have been writing a lot about animal models and their utility in research. They have a role. They definitely have a role. But we may now need to start taking a leap of faith and establishing standard or high quality in vitro assays in which the biologic or a putative, molecule or scaffold or cell works, and then having the guts enough to say, let us jump the gun of the animal species and try it in humans. End of the day, we are solving a human species problem, and we can keep on doing n number of animal trials, which takes a lot of time, takes a lot of money. You put up the results at every meeting, you put up an animal result data. If there are 2 surgeons in the 200 people meeting, they are the 2 who will be up on the mic saying, what is this? How is it relevant to me? And it happens consistently. And we are observing this again and again and again. So the question is, are those surgeons then ready to take that simple in silico or in vivo modeling that we have done in the labs and trial it in the patients? And that is when they falter. They get weakened on their knees. They don't want to they don't want to even talk about research because there may be an impact financially on their practice. So people are looking for solutions. But there's an opportunity here, maybe in this podcast and all, to call up all my surgical colleagues to participate more aggressively in trying to develop those solutions and to get that interface among those surgical colleagues and the lab-based colleagues strengthened, firmed, and actually ramped up. Otherwise, we will have the same problem. We'll have the same podcast 25 years from now, and we'll be talking about the same problem. So if we need to solve a problem, we really need to come together strongly. So the answer to your question, Zori, unfortunately lies that we need to increase that collaboration between the clinic and the research, and we need to do it fast and quick.
Thanks very much, Ashish. It's as it's becoming increasingly clear in this discussion, this is a very complicated subject, right? And you and Zori have nicely talked about biomechanics and so on and so forth. I guess, and we talked about biologics a little bit. So just very briefly, just a minute or two we have left. There's been lots of research about injections of stem cells into discs. Some have shown when they leak out, they cause bone formation. Some have shown other studies showing growth factors when they leak out, they can cause exogenous bone formation. So we talk about it. I guess my question to you really would be, in terms of biologic therapy, what do you think we should contemplate? Should we try and heal the annulus from the outside in or from the inside out? Perhaps an injection inside would help, as you talked about, is very different, the outer versus the inner. And would that maybe be a different way of thinking, I guess, perhaps, but it's something that makes me wonder that maybe that's a better approach. And I'll pass over to you, and I have to wrap up shortly. But
well, thanks for that, Mark. To that question, both you and I have done a lot of work, you with your signaling molecules and I with the discovery that we made in a lab as to one molecule, which is very important in the development of the disc and utilizing that and injecting. And we've both shown incredibly good annular repair. Here, when we started doing that work, we were just focused on the nucleus and structure. But you put these molecules in, and there's an incredible global sort of organ regeneration response that we have seen. So a simple answer to your question is, I think it has to be an inside-out strategy if we are going to put that molecule in, and that if we are able to demonstrate, as we have demonstrated, that the collagen fibrils, they basically recreate, I think that may be a good starting point to say that biomechanically this will be strong, because now you're seeing the collagen in its sort of trihelical structure sort of reorganize itself very well with these signaling molecules around the annulus. So the simple answer to that question is, it, in my opinion, has to be an inside-out strategy. And whether we start validate that in the sort of what I call the disc angina DDD situation, or whether we start thinking, and it is only from there that we will be able to bring it to the lumbar disc herniation situation, where the fraying of the tissue is much harder, bigger. So that is where we can think of combining it with some sort of a bring the tissues together strategy. But yeah, I would pin my hope on the biological molecule for the future and watch the space.
Yep. Okay. Well, cool. Thank you very much. It's great seeing you. And Zori, thank you as always for helping out with this. And Ashish, it was just terrific having your experience and expertise and insight. So thank you very much. And thank everybody for joining us on our 4th podcast. The next one will be all about nucleus. So it was a nice segue into that space. And we look forward to catching up with you the next time around. Any comments, Zori, from you before we wind up?
I just have a super quick question for Ashish and for both annulus and nucleus. Do you think that we don't have the regenerative therapy because we are still searching for the one, or maybe it's that we haven't identified the right patient population?
Another, Zori, you asked the most difficult questions. I'll let Mark ask me the next set of questions every time at the next podcast. So I think the second piece is the important piece, very important piece. And I think that is the piece that needs more definition. The problem is not us identifying the correct patient population. Frankly, every patient who has a spine and a bit of back pain could be an ideal situation. But the challenge will be, what will be the regulatory acceptance of a new indication? If you stand up in front of a regulator and say, I want to treat back pain, right? Yeah, how do you establish a control? What is it that you're going to control against? So my guess is that there will be a stepladder pathway to the whole thing. There has to be a strategy in utilizing or testing these molecules in a defined set of patients that is acceptable, which will also allow to give us better outcome measures, and then take it to the next level. More than likely, it'll be something like, well, we've got 10 patients who are ready to get a 1 level or 2 level fusion performed, right? So maybe if we can rescue those by doing a biologic, if we can bring that 10 down to 7, 6, or 8, would that be an accepted sort of success rate of 30% or 20%? I think that is where we will start off with. And once we have that molecule available, then we have investigator-initiated studies to define those subpopulations better, which again opens up a can of worms. How do you decide that this patient is the most suitable for spinal fusion? We don't have that consensus yet. There is some consensus around it in terms of 6 or 8 months of non-operative care. But again, that is, there are guidelines, but there are no accepted consensus across various regulatory agencies on that. So I think once we get that sorted out, and I think that is where the clinicians or NAS can really contribute, is say, to get this done, this is how we will accept it. This is the standard. You've got 5, 10 biologics. Let's all subject each one of them to this set of testing and then get it done. I think that'll be maybe a small part of the solution to a very complex problem of which patient and what outcome measures to use.
Okay, so the gauntlet's been thrown down.
Yeah.
All right, then I guess we'll have to wrap up. I think our time is up here. So, but thank you again, everybody, Zori and Ashish, very much. And have a great day and or evening or morning or whatever it is down under. And we look forward to catching up again soon. Take care, everybody.